Hello everyone, my name is Swetha Sampath. I am a final year medical student at Barts in London. Hope you're all doing okay. So today I will be giving a part of the PALS Haematology lecture series. If you guys have any questions about any of the slides, I will leave an email at the end and you can get in touch with us through that. So the topics we will cover are anemia, hemoglobinopathy, so we will look at sickle cell disease and thalassemia. We'll then look at malaria, then the hematological cancers, and finally we will look at the different vasculitic diseases. So before we start, just to give you a bit of a recap on the red cell indices on the full blood count, which is what we usually use in the differential diagnosis of different hematological conditions, especially the anemias. So firstly, HB, so you know that that's the concentration of hemoglobin in our blood. We then have a mean corpuscular volume. So this, what this is basically it's the mean volume of the red blood cells. So it's measured in femtoliters or FL, and the normal values are between 80 and 100 femtoliters. So you use this to decide whether an anemia is microcytic, normocytic, or macrocytic. So the HB and the MCV are the two most important parameters you would look at when it comes to anemias. You also have hematocrit, which basically shows the percentage of the blood that is actually made up of red blood cells. It's usually low in anemia and more serious conditions where there's bone marrow failure, such as in acute myeloid leukemias, and it can be high in conditions such as polycythemia and also if your patient is very dehydrated. Then we have RDW, which is also known as red cell distribution width. This is a measurement of the range of sizes of the red blood cells in our plasma. So if you have a higher value, it means there's more variation of red blood cell volumes. And this is known as anisocytosis. So this is when the cells are of different sizes. This is present in a lot of patients who have iron deficiency anemia, as well as B12 and folate deficiency related anemias. However, it is normal in other types of anemia, such as thalassemia. So you can use this to differentiate between the different types. So these are the main ones, but we also have MCH and MCHC. So MCH is the mean corpuscular hemoglobin, and MCHC is mean corpuscular hemoglobin concentration. So they both tell us the mean hemoglobin concentration in one red blood cell. Okay, so but the difference between them is that MCHC takes into account the volume of the red blood cell, so it's looking at concentration. They are not as important in anemias, but essentially they move up and down parallel to a mean cell volume. Okay, so it's just so that you know what these are when you look at a full blood count. Okay, so our first topic is anemia. This is a priority 1 topic in the syllabus, so we will go into more detail on this. So anemia can be defined as a reduction in the number of circulating red blood cells, which leads to a reduced hemoglobin concentration, hematocrit, or red blood cell count. There are 3 ways in which this can happen, so 3 mechanisms. So the first one is if you have a reduced production of red blood cells, obviously that could cause an anemia. Secondly, if there is increased red blood cell destruction, which then leads to a reduced RBC count, or if you have blood loss, then it's quite obvious how that might cause an anemia. Okay, so anemias have lots of different causes, and some of these include nutritional deficiencies, so that of iron, B12, vitamin B12, and folate. So these are the three main nutritional deficiencies. It can also be caused by hemoglobinopathies such as sickle cell disease and thalassemia, as well as infectious diseases. So we will look into all of this in more detail in the upcoming slides. So for the purposes of diagnosing a patient with anemia, in women, you would need their hemoglobin concentration to be less than 12 grams per deciliter to diagnose them with anemia. In men, this would be less than 13 grams per deciliter, and in someone who's pregnant, the value will be much lower. So if they have a hemoglobin of less than 11 grams, then you'd diagnose them with anemia. So next, let's look at how a patient with anemia might present. So this depends on what's causing the anemia, but generally a lot of patients are actually asymptomatic, and the anemia is usually found incidentally when someone does a full blood count. But you can also have some other symptoms such as fatigue. Patients might feel short of breath if they exert themselves. They might have palpitations. Some people actually might have worsening chest pain, which is quite a serious sign of anemia if they have it. And others might have a whooshing sound in the ears. So these are some of the things that they might feel. In terms of signs, if you have iron deficiency anemia, you might get conjunctival pallor, you can get koilonychia, which are spoon-shaped nails, and angular chelosis. If they have a B12 related anemia, they can get something called glossitis, which is when the tongue gets affected. I have some pictures coming up later on. If someone has a hemolytic anemia, then this can cause a jaundice, so a pre-hepatic jaundice, and because there is a hyperdynamic state in more advanced anemias, you might get signs such as a bounding pulse, tachycardia, or a flow murmur. Rarely, there are some patients who might present with signs such as pica, which is when they have a craving for ice or dirt. And in very severe cases, the anemia can lead to extramedullary hematopoiesis. So this is basically when blood cells start being made outside of the medullary bone. And this can be seen as hepatosplenomegaly or frontal bossing of the skull. So this is when the front of your skull gets larger, and this is a classic sign that you see in patients with thalassemia. In vitamin B12 deficiency related anemias, you can also get neurological signs, which we will also look at later on. Okay, so you do a full blood count and then you diagnose someone with anemia. So what do you do next? So you then look at the patient's mean cell volume. And like I said, normal values are between 80 and 100 femtoliters. Okay, so using this, you can classify the anemias into microcytic, which is if hemoglobin is less than the appropriate cutoff and the MCV is less than 80 femtoliters, or normocytic, which is when MCV is normal, or if they have a macrocytic anemia, which is when the MCV is above 100 femtoliters. So let's look at the different causes for each of the anemias. So for microcytic anemias, there is a mnemonic which you can use to remember it, and this is iron last. So iron stands obviously for iron deficiency anemia. L, lead poisoning. A, anemia of chronic disease. S, sideroblastic anemia. And T, thalassemia. So the mnemonic is iron last. in terms of causes of normocytic anemias, you have the 3 A's and the 2 H's. The A's being acute blood loss, anemia of chronic disease, and aplastic anemia, and the 2 H's being hemolytic anemia and hypothyroidism. Macrocytic anemias can be split into megaloblastic anemias and normoblastic anemias. So the megaloblastic anemias are the B12 and folate deficiencies, and normoblastic are macrocytic anemias that result due to excessive alcohol intake, reticulocytosis, liver disease, hypothyroidism, or pregnancy. So for all the anemias, you would then proceed to do a blood film. So this is the next step after you've done after you've looked at the FBC. And you can also, depending on what type of anemia it is, you can look at other things. So in microcytic anemias, you would want to do iron studies. You would want to look at ferritin. You would also want to look at your LFTs, USNEs, and if there is a patient with risk factors for hemoglobinopathies, then you would do a screen there. In normocytic anemias, you sort of do the same thing. You might also want to look at reticulocytes if you suspect hemolytic anemia, in which case it will be raised. You can look at LFTs. In hemolytic anemias, LDH is raised, and you might also want to look at a thyroid profile. And in macrocytic anemias, it's again the same, but you'd also want to check the TSH as well. Okay, so we're going to look at the main types of anemias from this part of the table. So the first one we're going to look at is iron deficiency anemia. So this is the most common cause of anemias. And if we look at what actually causes the iron deficiency anemia, this can be due to blood loss. So initially when someone loses blood, you get a normocytic anemia. However, if they keep losing the blood, it will then turn into an iron deficiency microcytic anemia. In young children especially, iron deficiency anemia is a result of poor dietary intake. It can also be due to malabsorption, which is the case in celiac disease. And in less economically developed countries, a major cause is hookworm infection. So if you suspect that someone has an iron deficiency anemia and you carry out all the appropriate tests we talked about, then you would see on the blood film a microcytic hyperchromic anemia picture with anisocytosis and poikilocytosis. Okay, so anisocytosis, as we talked about before, is when you have different sizes of red blood cells, and poikilocytosis is when you have different shapes. Obviously, you would see a reduced mean cell volume because it would be a microcytic anemia, and as a result, you would also see a reduced MCH and MCHC, and you would also want to do some iron studies. So in this, you would want to look at three main things. So the total iron binding capacity, which will be increased in iron deficiency states, because the body knows that there isn't enough iron, so it tries to increase the body's ability to hold on to iron. Transferrin is an iron transport molecule, so this will also be increased. But perhaps the more important marker is ferritin. So ferritin will be reduced in iron deficiency anemia. What ferritin is it's a iron storage molecule. So a combination of a microcytic anemia with reduced MCV and a reduced ferritin is very indicative of an iron deficiency anemia. So MCV and ferritin are the more important parameters to look at, basically. So you've now decided that your patient has an iron deficiency anemia. What would you do next? So firstly, you want to find out what's causing the iron deficiency. If there is no obvious cause, then this is an indication for you to investigate further. So according to the NICE guidelines, if your patient has an unexplained IDA, iron deficiency anemia, and is above 60 years of age, this is an indication for an emergency 2-week wait referral with suspected lower GI tract cancer. Similarly, if your patient has an iron deficiency anemia, is less than 50 and has rectal bleeding, again, this is an indication for 2-week urgent referral. If you get a patient, a lady who's above 55 years of age, has visible hematuria, low hemoglobin, then you want to send them for a pelvic ultrasound. If your patient is above the age of 55, is presenting with upper abdominal pain and a low hemoglobin, then you want to send them for upper GI endoscopy, and you're trying to see if they have an ulcer that's bleeding, or do they have some sort of malignancy. So you just definitely want to rule that out. Okay, so you've sent your patient for any appropriate investigations. You found the cause, and now you want to treat it. So how would you do this? So firstly, you would start off by replacing the iron that they are deficient in. So you start them on oral ferrous sulfate. The normal dose is 200 milligrams 3 times a day. And the bad thing about this is that it does have side effects. So a lot of patients experience constipation or nausea or abdominal discomfort, diarrhea. So a lot of them might not be taking the dose that they're meant to be. So if you get a patient who is not responding to oral ferrous sulfate, before you increase the dose or you switch them to IV iron, you may want to check that they are actually taking the medication at the correct dose. Okay, and of course, if this doesn't work, you can try increasing the dose. And if this is not working either, then you can treat them with IV iron. In fact, the patients who are on hemodialysis don't get oral ferrous sulfate; they get regular IV iron replacement. So just a side note, actually, so these are some pictures. So this is the koilonychia that I was talking about earlier. This is a sign of very severe iron deficiency anemia. And you don't usually see this a lot, but this is the spoon-shaped nails that you can see here. And this is a picture of glossitis. So this is not, this is actually for B12 deficiency, it's not for iron. And here you have angular stomatitis or cheilosis, where you can see these the redness around the corners of the mouth. So just a side note on transfusion. So when would you transfuse someone? So this is not just for iron deficiency anemias, but for anyone who aren't elderly, have cardiovascular disease or respiratory disease. If their hemoglobin drops below 70 grams per deciliter, you would transfuse them with red cell concentrates. In this group of patients, elderly, cardiovascular, resp disease, if their hemoglobin drops below 80, you would then transfuse them with red cell concentrates. Or if you have a patient with a significant blood loss, more than about 30% of their blood volume, 1.5 liters, then you'd again think about transfusing them with red cell concentrates. In very severe cases of symptomatic anemia. So if they have worsening chest pain, they're having a lot of tachycardia, or if they have severe orthostatic hypotension, here again you would consider transfusing. And in a sickle cell crisis, if it's quite severe, again here you would consider transfusion. Okay, so now we're going to move on to anemia of chronic disease. So there are three mechanisms by which an anemia can be caused by having certain chronic diseases. So the first one is if you have a defect in how iron is used during erythropoiesis, this can therefore over time lead to an anemia. And also, if in a lot of chronic diseases which cause these anemias, there is increased cytokine activity, which can also reduce the lifespan of red blood cells from 3 months to much less, which over time again can cause lead to anemia. If the patients have a reduced EPO production, which is the hormone that causes red blood cell production, then this can also lead to an anemia. Okay, so what are the diseases that can cause anemia of chronic disease? So things like rheumatoid arthritis, certain types of vasculitic conditions, certain malignancies, if someone has a chronic infection, someone who has renal failure, all of these diseases and many more diseases can cause anemia of chronic disease. So what would you find in this anemia? So you would, most of the time, you would find a mild normocytic anemia, and your hemoglobin would probably be above 80 grams per deciliter. And in some patients, however, it can be a microcytic anemia. Most of the time, though, it's normocytic. So you would therefore either find a normal or reduced main cell volume. You might find a normal or increased ferritin. Actually, an important thing about ferritin is that I said that it's reduced in iron deficiency anemia. Apart from it having an involvement with storing iron, it is also an acute phase protein. So in situations where there is a lot of inflammation, the levels of ferritin might go up, which is one of the reasons why it goes up in anemia of chronic disease. Okay, and also in these conditions, you would also might have raised inflammatory markers because of underlying inflammation, malignancy, or infection. In terms of treatment, you could treat the underlying cause more effectively. This might help by reducing the inflammation and reducing the rate at which the underlying mechanisms is causing the anemia. And in things like renal failure, you can then start giving patients EPO to help them produce more red blood cells. Okay, so next we have the other two microcytic anemias, so sideroblastic anemia and lead poisoning. Okay, so sideroblastic anemia is an anemia that has many different causes. It can be congenital, it can be acquired from chemotherapy, from anti-TB drugs, as a result of irradiation or excessive alcohol intake. So there are quite a few different causes, but they are basically all defined by having on a blood film of the marrow, of having ringed sideroblasts in the marrow. So the picture on the right here shows that. So you can see a ringed sideroblast within the bone marrow, which is basically when there is when there is excessive iron deposition in the mitochondria because of ineffective erythropoiesis. So when might you actually think that someone has this? If a microcytic anemia is not responding to iron, then think sideroblastic anemia. So this is basically what a sideroblast looks like. And then we have lead poisoning. So lead poisoning usually in patients presents with abdominal pain, constipation, headache, memory problems, so it's quite vague. But anemia only starts occurring when the level of the lead rises more than 50. So it's not always there, but it can be. So, and if you look at a blood film, if you suspect someone is having this, then you will be able to see microcytic hyperchromic cells. And you might also see something called basophilic stippling. So this is a basophil here. You can see that here, and essentially basophilic stippling can occur in other anemias as well, and other conditions. It's not very specific to lead poisoning, but nevertheless does exist. Okay, so next we will look at the macrocytic anemias. So we'll first talk about the megaloblastic kind, which are caused by B12 and folate deficiencies. So a megaloblast is a cell in which nuclear maturation is delayed compared to the cytoplasm. So the reason why B12 and folate cause this is because these two, the vitamin and the mineral, they are needed for DNA synthesis. So if there is a deficiency, then it can interfere with how the cells develop, and therefore leading to a megaloblastic anemia. So the most common cause of macrocytic anemia in the Western world is pernicious anemia, which is an autoimmune condition, which we will talk about in the next slide. So before that, I'm going to talk to you about folate and B12 deficiencies and sort of compare them, because they both produce macrocytic anemias. Okay, so folate deficiencies. Folate is found is a mineral, and it's found in green vegetables, nuts, yeast, and liver. B12 deficiencies, on the other hand, B12 is a vitamin, and it's found in meat, in dairy, and fish. Causes of folate deficiency can be dietary due to increased demand. So in pregnancy, women are advised to take folate up until 12 weeks because there is an increased demand. Also, if there's reduced absorption, like in IBD or celiac, as well as if using certain drugs, this can also cause folate deficiency. So methotrexate is a good example. So patients who are on methotrexate have to also take folate supplements along with the methotrexate in order to avoid the deficiency. B12 deficiencies again can be caused by poor dietary intake, but also by pernicious anemia, which is the most common cause, or as a result of malabsorption from Crohn's, celiac, etc. So what would happen? What happens in a folate deficiency? What are the signs? So in this, the biggest risk in folate deficiency is that it can cause neural tube defects in pregnancy, which is why pregnant women should take folate ideally from before conception, but also definitely up until 12 weeks. And they also, if you look at a blood film, you will see a macrocytic anemia with hypersegmented neutrophils. So this is shown in the picture up here. You can see that these neutrophils have lots of segmentations. The nucleus have lots of segmentation, so that's the hypersegmented neutrophils. Whereas in B12 deficiency, you can get if there is a hemolysis. It can cause a jaundice, which causes a lemon tinge. It can cause a glossitis, which is a picture that I showed earlier, as well as a chelosis. Patients might also have psychiatric symptoms, so they might be quite irritable, depressed, they might develop a dementia. So it's all quite general, but nevertheless, it can still happen. And the more important neurological complications are that patients can get, well, they can get paresthesias, so less important ones, but the most important one is subacute combined degeneration of the cord. So this is when there is loss of the dorsal column, so you can get reduced proprioception and vibration and joint position sense. So what happens then is that patients will present with an ataxia or stiffness, and then later on their motor neurons can get affected as well. However, pain and temperature is preserved because it's just the dorsal column that's being affected. So in terms of treatment, how would you treat folate deficiency? So you do the same thing again. You want to look for a cause, try and rectify the cause of the anemia. In pregnant females, as I said before, folate, and also in others who have folate deficiency, you can replace it orally. But importantly, you should never give folate on its own without B12 unless you have confirmed that the patient has normal B12 levels. This is because if you give someone folate but they have an unknown low B12, this can worsen, the folate can worsen the subacute combined degeneration of the cord as a result of the low B12. So you need to be careful with that. And in B12 deficiency, you replace the vitamin by giving them intramuscular hydroxycobalamin injections. Okay, so this slide talks about pernicious anemia. So in this, there is an autoimmune atrophic gastritis. So essentially, you get antibodies to gastric parietal cells, which make acid, an intrinsic factor, which absorbs B12. And as a result, you get achlorhydria, which is a lack of acid, and a reduced absorption of vitamin B12. It's more common in women, and it develops around middle age, and it's the most common cause of a macrocytic anemia. Because it's autoimmune, it's associated with other autoimmune conditions such as Addison's, thyroid-related autoimmune conditions, and also in patients with pernicious anemia, carcinoma of the stomach is 3 times more common. In terms of presentation, you might get a weak, tired patient. They might have a mild jaundice if there is underlying hemolysis. They might have the sore tongue. They might have the neurological signs, at which point you would then do a full blood count, and then you'd want to do a blood film. In terms of treatment, there is no cure for it, but you can replace the B12 through IM injections, but this has to be done lifelong. So in patients with pernicious anemia, they need lifelong vitamin B12 injections, and it's usually 3 monthly. At the start, if the levels are very low, you might have injections more often, and then once they're stabilized, it will be 3 monthly. Okay, so finally, we're going to look at hemolytic anemias. So this is the last type of anemia we're going to look at. So hemolysis is essentially the premature breakdown of red blood cells. There are many different causes of hemolysis and hemolytic anemias, but a way in which we can classify them is you can get intravascular hemolysis or you can get extravascular. So extravascular would be within the reticuloendothelial system, which is organs such as the spleen. And you can also split them up into acquired hemolytic anemias, which is of immune origin or due to infection, versus inherited, so as a result of enzyme defects, membrane defects, or hemoglobin defects. So there are some, I'm not going to go into a lot of details about all the different causes, but I will talk about some of the general features of hemolytic anemias. So if you are having increased red blood cell breakdown due to hemolysis, you might then develop an anemia, obviously. You can have an increased bilirubin as a result of excessive heme breakdown. And you can also have increased lactate dehydrogenase, which is released from red blood cells when they hemolyze. If there is increased red blood cell breakdown, you might then go on to have increased red blood cell production, in which case you might get increased reticulocytes and therefore an increased mean cell volume. If the hemolysis is mainly extravascular, such as if it's happening in the spleen, you might get a splenomegaly. If it's mostly intravascular, you might get an increase in plasma hemoglobin because it gets released within the vessels, and you might also get a hemoglobinuria or a hemosideриnuria when the blood gets filtered by the kidneys. And the way to find a cause is you start off by doing blood film, which can help. There is also another test called the direct antiglobulin test, or the Coombs test, which, if positive, means that the cause of the hemolysis is immune in origin. And the way it works is that it detects antibodies on the red blood cell of the patient. So if the antibodies are there, this means that it's an immune process that's causing the hemolysis. Autoimmune idiopathic hemolytic anemia, which is the AIHA, is a condition which is defined by a positive DAT test or a positive Coombs test. Okay, so that's the end of the anemias. So as I said before, this is a priority 1 topic, so make sure that you spend some time looking at the different types and the different tests. Also try look at some blood films as well for your exams. So our next topic is hemoglobinopathies. There are many different kinds, but the 2 main ones we're going to focus on today in this lecture are sickle cell anemia and thalassemia. Okay, so we'll look at sickle cell anemia first. So this is an autosomal recessive condition in which there is an abnormal synthesis of beta globin chains. So adult hemoglobin has 4 globin chains, 2 alpha, 2 beta. So it's alpha 2, beta 2. That's HbA, which is the adult hemoglobin. You can also have HbF, which is fetal hemoglobin, where you have 2 alpha globins and 2 gamma globins, alpha 2, gamma 2. And you can also have hemoglobin A2, which is another type of adult hemoglobin, which is made up of 2 alpha chains, 2 delta chains, so alpha 2, delta 2. So these are the different types, and in HbA, because you have the beta globin chains, this is what's affected in sickle cell anemia, and this is a result of so basically the beta subunit has in the beta globin gene, which is found on chromosome 11, is meant to have the amino acid glutamic acid at position 6. Instead of this, there is a valine present. So actually it's better if I show it to you through this picture. So normally you'd have glutamic acid in amino acid 6 of the beta globin chain of chromosome 11. However, if due to a point mutation it becomes valine, this is what leads to sickle cell disease. And what essentially happens is that the shape in a hypoxic environment, these red blood cells will then polymerize, they stick together and form sickle shapes, which then, because they're stuck together, they can go occlude different blood vessels. The smaller the blood vessel, the easier it is to occlude it, and they can also hemolyze and cause sickle cell crises. So that's the underlying genetic state in sickle cell anemia. Sickle cell anemia is more common in people of African descent. So in the UK, 10% of Afro-Caribbeans are carriers of the sickle cell trait. And in terms of presentation, most people will present at around 3 to 4 months of age, which is when hemoglobin, the fetal hemoglobin, is usually replaced by adult hemoglobin. But in this case, it gets replaced by HbS. So it can present in different ways. So there are 3 ways we're going to look at. So the first one is a vaso-occlusive crisis. So in this, the red cells which have stuck together can occlude small vessels, which is often in the bone marrow of the long bones, and they can cause severe pain. So the children might have pain in their tummy, in their back, in their legs, in their chest. So, and usually they're in quite a lot of pain, and this can be triggered by things like having an infection, or if they become very dehydrated, if they get very cold, or are in a hypoxic state. In younger children, they also can get dactylitis in their small joints. Another way in which they can present is through an aplastic crisis. So if children with sickle cell disease get a parvovirus infection, so parvovirus B19 causes the slap cheek syndrome, usually. So if they get this can lead to an aplastic crisis, when there is a sudden drop of red blood cell production in the bone marrow. In these cases, the children might need transfusion if it's not getting better by itself. And finally, another way in which they can present is through a sequestration crisis. So this happens mainly in children, where blood starts to pool within the organs, so be it the spleen or the liver. It can then lead to splenohepatomegaly and can lead to an anemia or shock due to poor end organ perfusion of the other organs. So this is quite serious. So in this case, they will need an urgent transfusion. In terms of how do you diagnose sickle cell disease, so if there are risk factors present at birth, you would do or if they present with symptoms, you'd do something called hemoglobin electrophoresis. So this is what the picture over here at the bottom shows. So as you can see here, so the first phenotype is a sickle cell trait. So in this, this patient is a carrier, so they have one HbS allele and one HbA allele, which is the normal one. So they have both, they're a carrier. The second phenotype is the actual sickle cell anemia, where they have 2 copies of HbS, and the last phenotype is a patient with normal HbA. Okay. So how do you treat sickle cell anemia? So there is no cure for sickle cell anemia, but if patients are having frequent crises, then you can give them hydroxycarbamide, which is a drug that works by increasing fetal hemoglobin production. So 97% of the blood is made up of HbA, in these patients, it would be HBS. The remaining 3% is made up of HB fetal hemoglobin and HbA2, which is the third type of hemoglobin that I talked about earlier. So these make up 3%. So hydroxycarbamide increases the percentage of fetal hemoglobin, and as we know, fetal hemoglobin has an increased affinity for oxygen. So this will then help oxygenating these patients a bit better. Over time, splenic infarction occurs in individuals with sickle cell disease, and this can lead to hyposplenism, which means that they can go into an immune deficient state. In these cases, the patients might need antibiotic prophylaxis to make sure they don't catch frequent infections, which can then lead to even more crises, and so on. In terms of complications, as I talked about before, patients can present with sickle cell crisis, which can be due to any of the three things: sequestration, vaso-occlusive, or aplastic mechanisms. So in this case, the most important thing that you want to do is that you want to get the pain under control. So you want to give them prompt analgesia. Usually, the only thing they probably respond to would be morphine, IV morphine. So you want to get that to them as soon as possible. You also want to do some investigation, so do some bloods to see if how bad their anemia is. Also do some blood cultures to see if they have an infection, and cross-match in case they need a transfusion later on. Then you want to rehydrate them with IV fluids. If they are hypoxic, you can give them oxygen. Consider antibiotics if showing signs of infection, such as fever, and in more severe cases, you'd want to consider transfusion. The other way in which sickle cell anemia can present with a complication is through acute chest syndrome. So in this, patients can still have a lot of pain, but they also present with more respiratory symptoms, such as a cough, wheeze, tachypnea. They might also have a fever and a tachycardia. And when you do a chest x-ray, you will then see a lot of pulmonary infiltrates. So if this is the case, then you want to treat with oxygen to help with the hypoxia. You want to give them analgesia if they're in pain, antibiotics. If wheezing, coughing, then you can give them bronchodilators such as salbutamol. And in severe conditions, you can transfuse them and consider moving them to ITU. Okay, so next we'll talk about the thalassemias. These are also hemoglobinopathies and can be divided into alpha and beta thalassemias, with beta being more common. So beta thalassemia is a disease that is a result of a point mutation in chromosome 11, which is where the beta globin gene is. So essentially what happens is that there is, as a result of the mutation, you have a defective globin chain production. So then what happens is the unmatched globins can cause damage of the red blood cell membrane, which then leads to hemolysis, or all of this happening whilst within the bone marrow. Whereas in sickle cell disease, it can happen within the marrow, but also within blood vessels. So in beta thalassemia, patients can be affected to different extents. So if you have something called beta thalassemia minor, or trait, this is when you are a carrier of the gene, of the symptomatic allele, but overall you will be asymptomatic. So you might, on blood film, you might have a mild hyperchromic microcytic anemia, but most of the time you wouldn't have any symptoms. if you have something called beta thalassemia intermedia, so this is when you have a mild homozygous mutation, so you're not just a carrier anymore, and usually this happens because of co-inheritance of another hemoglobinopathy. So in this case, you would have a moderate anemia. You might have symptoms. You probably will have symptoms, but it won't be to the extent that you need a lot of transfusions. If you have beta thalassemia major, so this is when both beta globin chains are abnormal, and this causes a severe anemia. Patients will have bone marrow failure within the first year of life. So in this situation, you would then the patients will then need lifelong blood transfusions, and if they're having a lot of blood transfusions, it can lead to an overload of iron in the system, in which case they will need iron chelation therapy as well. So what would you see when you do tests for if you suspect beta thalassemia major? You will see a very hypochromic microcytic picture. You might see something called target cells. You can see nucleated cells. The level of HbF will be increased because the body's trying to sort of increase the capacity to oxygenate itself, and HbA2 might be increased, might not be, but HbA will be absent. So the pictures over here on the right at the top is a sign called frontal bossing. So this is when extramedullary hematopoiesis happens in the skull, which causes an enlargement of the skull, as you can see in this child. And at the bottom is a child with thalassemia who has splenomegaly, which is also as a result of extramedullary hematopoiesis. Okay, so next we have alpha thalassemia. So unlike beta thalassemia, which has it has one beta globin gene, alpha thalassemia involves two genes because alpha globin is coded for by two genes, which are both on chromosome 16. So the severity of the alpha thalassemia depends on how many of the alleles are affected out of the four. So if only one or two alleles are affected, you will have a hypochromic microcytic picture, but hemoglobin concentration is usually normal. If three alleles are affected, then you will have a hypochromic microcytic picture with splenomegaly. So this is known as HBH disease, which will then cause things like a frontal bossing and splenomegaly. However, if you have all four of your alleles affected, you will be a homozygote, and this state is incompatible with life, and the fetus will develop hydrops fetalis and will probably die in utero. This type of hemoglobin is known as hemoglobin Bart's, and of course it's named after the place in which this hemoglobin was found, which was over at the West Smithfield campus. Okay. Right, so now we're going to move on to malaria. So we're about halfway through the lecture. Okay, so malaria is a mosquito-borne life-threatening infectious disease which is transmitted by the female Anopheles mosquito. Most of you probably already know this. And if you want to know how many cases we have worldwide each year, there are about 228 million cases around the world, around 400,000 deaths as a result of malaria in 2018. The most vulnerable group are children under 5, and the WHO African regions carry a disproportionately high share of the global malaria burden, which is around 93% of the cases. And you can see from this map here that probably parts of Africa are the most affected, followed by other countries which sort of lie along the tropics. So warm, humid climates in tropical regions are where malaria is most endemic. So the Anopheles is the vector for malaria, but the actual cause of malaria is a protozoan, which is a single-celled eukaryote of the genus Plasmodium. Okay, so the genus is Plasmodium, and within that you can have 5 species. So the most common ones are falciparum and vivax and ovale, and the less common ones are malaria and knowlesi. So this table compares falciparum pneumonia to non-falciparum. So the reason they divide it into this is because falciparum malaria causes a lot of the malaria cases, and is also quite causes the more severe cases as well. So they group the other ones into non-falciparum. In terms of presentation of falciparum malaria, you can have general features such as headache, fever, anemia, but you might also have more severe features such as a more severe anemia or jaundice or splenomegaly. Whereas in non-falciparum, you can still get these symptoms and signs, but it's just not as severe as falciparum. One thing that's common to all the different types of malaria is that the symptoms can cycle, so they occur in cycles, and how often this happens can help decide what type of pneumonia, sorry, I keep saying pneumonia, I meant malaria it is. So falciparum malaria, vivax and ovale can usually cycle every 2 days, so 48 hours, whereas Plasmodium malariae cycles every 72 hours, so 3 days. In terms of complications, it's usually falciparum that presents with complications, and these can be cerebral malaria, which is when the patient can have seizures or go into a coma. They can have an acute renal failure. They can have acute respiratory distress syndrome. They can be hypoglycemic or have DIC, which is disseminated intravascular coagulation. Non-falciparum malaria, in this, there aren't that many complications really, but Plasmodium malariae, so this species, has a link to glomerulonephritis. It's quite rare for it to happen, but there is an established link between the two. In terms of treatment, in uncomplicated falciparum malaria, you treat this with artemisinin-based combination therapies, or ACTs. You can start off as oral treatment, but if you decide that this patient has a severe malaria, then you can switch to IV. For non-falciparum malaria, you would treat these patients with chloroquine, and you can also give them primaquine after giving them chloroquine. But if you are going to give primaquine, you want to check the patient's G6PD status, as if they have a deficiency, this can lead to hemolysis if they take primaquine. Some other points which are worth remembering is that the incubation period, the average incubation period for malaria is about 7 days. So you want to keep this in mind when you're taking a travel history from a patient. They can also have different stages of the fever. So first off, they might start with a shivering type of fever, which can then transform into the patient feeling quite hot and looking quite flushed, and then which can then become into a sweat phase where the patient starts sweating quite a lot. The interesting thing about Plasmodium vivax and ovale is that they can relapse after years, because the hypnocytes lay latent within the liver for years and then they can relapse. whereas the others don't really do that, the other species. In terms of diagnosis, if you suspect someone has malaria, first thing you want to do is to get thick and thin blood films, which will help with the diagnosis. There are also rapid antigen tests which have been developed, which are being used now. And you also want to check the parasitemia level in the blood if the patient, especially in falciparum malaria. So if the parasitemia level is above 2%, this is a value you might want to remember, this means that the malaria is severe. If the patient has severe malaria and it's falciparum, you have to switch them from oral ACT therapy to IV. If the parasitemia is above 10%, you need to take them to ITU. There are some other features which also make someone fall into the severe malaria category, which I think, yeah, I've got here. So any one of these features here can push a patient into the severe malaria category. They all involve organ involvement, essentially. So the only one that's a bit weird is the black water fever, which is a severe clinical syndrome characterized by intravascular hemolysis, hemoglobinuria, and acute renal failure. If the patient doesn't really have any of this but still fall into this group, so children, HIV/immunocompromised patients, or pregnant women, then again you would treat them as if they're having a severe malaria. So the picture here is showing the life cycle of the Plasmodium. So it starts off with the Anopheles mosquito, which infects the host, releases sporozoites, which then go into the liver, and as hypnocytes, and they then form schizons, and these schizons can rupture and release merozytes. And I think this process, how often this process happens, is what decides the cyclical fever that patients with malaria get. So the merozytes then go into the red blood cells, and this then leads to the erythrocytic stage. And of course, if it's circulating in the blood, another mosquito can come along, and the red blood cells can then be transferred to the mosquito. Okay, right. So that's the end of malaria. So now we're going to move on to the hematological cancers. Okay, so in this section we will cover ALL, so acute lymphoblastic leukemia. We'll look at acute myeloid leukemia, chronic lymphocytic leukemia, and chronic myeloid leukemias, and we'll also look at Hodgkin and non-Hodgkin lymphomas. Okay, so let's start off with ALL. So acute lymphoblastic leukemia is when there is bone marrow proliferation of non-functional white blood cells of the lymphocytic cell line. If it's of the myeloid cell line, then it would be an acute myeloid leukemia. It's the most common malignancy in children. The incidence is highest in 2 to 5 year olds, and it's slightly more common in boys. There is also a smaller second peak in middle age. So there is no obvious cause of acute lymphocytic leukemia ALL, but having prior alkylating chemotherapy or ionizing radiation is a risk. Patients with Down syndrome are also associated with an increased risk. So how might a child who's about 3 years old present with bone marrow, with ALL? So essentially they present with signs and symptoms of bone marrow failure. So they might have an anemia, and as a result might be quite pale or quite a bit tired all the time. They might have a neutropenia, which means they're getting frequent infections, and they might have a thrombocytopenia, and as a result have easy bruising, or they might develop petechial rashes, and perhaps more so in adults, they might be getting B symptoms such as night sweats, weight loss, etc., and also might have painless lymphadenopathy. So the lymphadenopathy is a differentiating feature between lymphocytic leukemias and myeloid leukemias, but I'll talk about that later on. Some other features that they might have include hepatosplenomegaly. They might have bone pain. They might be getting frequent fevers without a real cause, or they might also have testicular swelling. So how do you test for ALL? So you want to do a marrow film. So in this you will see large blasts. So if you look at the slide over here, on the right, you can see the very large blasts occurring throughout the film. You also, if you do cytogenetics, you might see a Philadelphia translocation. So this is between chromosome 9 and chromosome 22, which leads to a fusion of BCR-ABL. So you might see that, but you confirm by doing a bone marrow aspiration and biopsy. And you look at the percentage of lymphoblasts to see if it's above 20%. Okay, in terms of treatment, chemotherapy is very effective in children. Around 85% of children go into remission with chemo. If this doesn't work, especially in adults who get ALL, then you can do an allogenic stem cell transplant. So next we have AML. So this is a leukemia in which there is bone marrow proliferation of non-functional white blood cells of the myeloid line this time. This mostly affects adults. Risk factors, the most common identifiable cause are having an existing myelodysplastic or myeloproliferative disorder, but exposure to ionizing radiation and having Down syndrome is also a risk factor. Patients, again, similar to ALL, they might have the anemia, they might have the thrombocytopenia and the hepatosplenomegaly, but what's different in AML is that they might also have skin and CNS involvement. When you look at a film, you will be able to see something called hour rods. So in this film, if you see, there is a little sort of line coming off of here. So what they are cytoplasmic inclusion bodies, and you only see these in AML. So if you see an hour rod, or if they say there is an hour rod in an exam question, then you want to immediately think about the possibility of it being AML. And compared to ALL, in AML you get larger blasts. They're larger than ALL, but also the nuclei tend to be more bilobed. Diagnosis, again, you look bone marrow aspiration and biopsy confirms the diagnosis. You look to see if the myeloblasts are more than 20%. Cytogenetics you might see a translocation between chromosome 15 and 17 as well. Yeah, and in terms of treatment, it's similar to ALL. You do chemo. If that doesn't work, you do stem cell. You do an allogenic stem cell transplant. So just make sure that you are able to differentiate between ALL and AML, because they're both acute leukemias. So you want to consider the age of the patient, you want to consider the symptoms. So in ALL, painless lymphadenopathy, lymphadenopathy is more common to lymphocytic malignancies. In myeloid malignancies, you don't really get lymphadenopathy. And obviously here you are getting some skin involvement as well, CNS involvement, and also using the film as well, you can differentiate between the two. Okay, so next we will move on to chronic lymphocytic leukemia. So this is the most common leukemia in adults, and it presents, the median age of presentation is at about 70, so it affects older adults, whereas CML affects people around 50 to 60 years of age. So how might they present? So again, because it's a lymphocytic leukemia, they might get the lymphadenopathy. They might present with general features such as fatigue. They might have increased infections, chronic pruritus, so itching all over. But around half of the patients are actually asymptomatic, and the diagnosis is picked up incidentally. If you look at the film, you can see that you have you don't really have large blasts, sort of like large cells, as you would do in a more acute leukemia. The cells are much smaller, but nevertheless, you can see that the neoplastic lymphocytes, so these ones here, and here, they are a bit larger than the red blood cells, the normal cells. And you can also see some smudge cells, so these are the ones shown using the arrowheads. This is basically because the cells in CLL are so fragile that when you actually make a slide, the cells sort of smudge. That's why you get it. In terms of treatment, treatment is not always needed in CLL because even if you give them chemotherapy or monoclonal antibodies, it doesn't always improve their survival because it's seen as quite low as like a slow growing leukemia, so it's very low grade. So it's not always needed, but in some cases patients are treated with chemo and MABs. And one of the complications that you need to remember about CLL is that it can lead to something called the Richter transformation, which is when a CLL transforms into a high-grade non-Hodgkin's lymphoma. So this is something that's different from CML and all the acute leukemias as well. So just keep that in mind. Okay, so finally, the last leukemia is CML, chronic myeloid leukemia. So this is malignancy of hematopoietic stem cells with excessive myeloid proliferation. The cause can be, again, the BCR-ABL fusion gene due to the Philadelphia chromosome. So it can cause both CML and, I think it was, yeah, ALL and CML. Yep, and the peak age of presentation is around 50 to 60 years of age. So CML is a bit more chronic, so it presents in a few stages. So the first one is a chronic stage. This can last up to 10 years, where the patient might have weight loss, fever, night sweats, fatigue, splenomegaly, these sort of symptoms. The splenomegaly might not be very apparent, not very palpable, but they might experience some discomfort in the left side of the abdomen. Then you get the accelerated phase, in which you have an anemia, you might have neutropenia leading to frequent infections, and at this stage you can get a palpable splenomegaly. And then this can then progress into the terminal phase, which is called the blast crisis. And at this stage, CML will resemble an acute leukemia. So if you look at the film, you would see a lot of blasts and can progress to bone marrow failure. So these are the different stages of CML. You might ask, how will this look on a film? So here you go. So this is the chronic stage of a patient of CML in a patient who sorry. Yeah, so it's CML at the chronic stage, so it's not the blast stage. So in this, you can see there is a symphony of different cells. You can see all sorts of different cells here. You can see myelocytes. You can see basophils. So the arrows are basophils over here. The arrowheads are eosinophils. You can see myelocytes of different stages, so promyelocytes, myelocytes, different maturations. So this is quite a defining picture of the chronic stage of CML. Okay. So yeah, on tests you can see we saw the basophilia, the eosinophilia, the leukocytosis, all of this. And if you look at cytogenetics, you might see the BCR-ABL fusion gene. And in terms of treatment, first line is tyrosine kinase inhibitors called imatinib. This is what's given first line to most patients. And if that doesn't work, you would then try an allogenic stem cell transplant. If the patient has already gone into the blast phase, you would treat it as if it's an acute leukemia with chemo. Okay. Okay, so finally we have the lymphomas. So we've done the leukemias. So lymphomas affect the B cells. They can affect T cells and as well as the natural killer cells. What's the difference between lymphomas and lymphocytic leukemias, you may ask, as they both seem to affect lymphocytes. So the difference is that leukemias are cancers that occur in the bone marrow and the blood, whereas lymphomas, as it says in the name, are cancers of the lymph nodes. So the reason why you have these cells within the lymph nodes is, as we know, is because that the primary lymphoid organs are where B cells, T cells go from the bone marrow. They go there to mature and get activated. So they're the site of B cell maturation. So that's why you get lymphomas. Okay, so lymphomas are divided into Hodgkin lymphomas and non-Hodgkin lymphomas. So let's just look at the differences between the two. So firstly, Hodgkin lymphoma. This is a B-cell lymphoma. It peaks at around the third decade of life, the incidence of it, and also between the sixth and eighth decade as well. So it's a bimodal peak. Risks of this include a previous EBV infection. If someone has had infectious mononucleosis due to EBV, this is a risk factor. And also if they are in an immunodeficient state, this is also a risk factor for lymphomas. So patients who have HIV, lymphoma is quite a well-recognized complication. So typically patients will present with painless cervical lymphadenopathy, so they find a lymph node that's enlarged, a rubbery, hard, firm lymph node that's not movable. They might find that anywhere in their body, so this is one of the typical presentations. But they might also, a lot of the time, just have fevers and night sweats, like vague symptoms, involuntary weight loss. So these are the B symptoms that they might have. They might also have cyclical fevers, which is associated with Hodgkin's lymphoma, and also something that comes up in exams is pain on alcohol intake. So cyclical fevers and pain on alcohol intake, they're not very common, but if patients do have this, it's quite specific to Hodgkin's lymphoma. If you do tests by excising the suspicious nodes and performing histology, you might see a Reed-Steinberg cell. So this you can see in the picture here. So it's this weird looking alien face thing that you can see. So essentially they are large abnormal lymphocytes that may or may not contain more than one nucleus. So there you go, Reed-Steinberg cell. That's very classic of a Hodgkin lymphoma. Treatment is usually radiation and chemo. We also have non-Hodgkin's lymphoma, which you can classify into B cell, T cell, NK cell type, but also into low and high grade non-Hodgkin lymphomas. It's the most common hematopoietic neoplasm. It peaks at around 50 years, above 50 years of age. But the high-grade variety is more common in younger people. Risk factors include the chromosome 14-18 translocation, also infections such as EBV, HIV, and autoimmune diseases such as Hashimoto's thyroiditis and rheumatoid arthritis. Patients again present with a painless lymphadenopathy, hepatosplenomegaly, B symptoms, fatigue, and so on. And you would do the same test, really, excisional lymph node biopsy, and look at and do histology on it. And in terms of treatment, it depends on what type of non-Hodgkin's lymphoma it is. So in some cases, you would want to watch and wait. In more aggressive tumors, you do chemotherapy using the CHOP regimen, and maybe even some radiation. Right, so that's the end of the cancers. So next we have our final topic of this lecture, which are the vasculitic conditions. So systemic vasculitis is a name that you give to a group of autoimmune conditions which is caused by the inflammation of the walls of the blood vessels. It can affect different parts of the body depending on what type of blood vessel is being affected. So your skin can be affected, your lungs, your kidneys, nervous system, sinuses, etc., etc. It can be classified by the size of the blood vessel that it mainly affects. So you can classify it into large vessel vasculitis, which is made up of giant cell arteritis and Takayasu's arteritis, into medium cell vasculitis, which have polyarteritis nodosa and Kawasaki's disease in them, and also small vessel vasculitis, which is made up of IgA vasculitis, which is also known as Hinoch-Schönlein purpura, anti-GBM disease, also known as Goodpasture syndrome, granulomatosis with polyangiitis, which used to be called Wenger's, but Wenger's granulomatosis, but the name was changed. It's not used anymore. And also eosinophilic granulomatosis with polyangiitis, which is known as Churg-Strauss. So I've just written the actual pathology-related names here. Oh yeah, you actually have it here. Okay, so we're going to look at all these different types of vasculitis in a bit more detail, so you'll know how to recognize which one it is, which is probably what most of the questions might be based on in your exams. Okay, so large vessel vasculitis. Firstly, you have giant cell arteritis. This is when you have a systemic granulomatous arteritis of large and medium arteries, but mostly it's I think it's large. Temporal arteritis is the most common type. and this condition is also associated with polymyalgia rheumatica, which is when a condition in which there is proximal muscle stiffness, so of your shoulders and your hips. And yeah, so they're quite closely linked to PMR and temporal arthritis. So how might someone with temporal arthritis present? So it's a rule of 60s, so it's typically a 60-year-old patient who presents with a headache, a jaw claudication, and tender palpable temporal arteries. So this is like the classic scenario in which with symptoms they might present with. They might also have visual disturbances. So because the temporal artery gives out a branch of an artery branch which supplies a part of the eye, disturbances of this artery can lead to vision loss, which is the most severe complication of giant cell arthritis. If a patient presents with visual disturbances and you think they might have temporal arthritis, this is an indication for you to send them for same-day ophthalmology review. In terms of tests, they will have a high ESR, so it will be in the 60s, and so that's a rule of 60. So 60-year-old patient, 60 ESR, more than 60 ESR, and you treat with 60 milligrams of prednisolone. It's the easier way to remember it. So other tests you can do is that you can do a biopsy of the artery, but sometimes they might be normal because of skip lesions. So the part of the artery that you biopsy might not have the pathology, but it doesn't mean that you can rule it out. In terms of treatment, you give high-dose prednisolone, around 50 to 60 milligrams, and like I said earlier, urgent ophthalmology review in patients with visual disturbance, because it might be permanent to the visual loss. So that's giant cell arthritis. So now we have Takayasu's arthritis, which is more common in patients of Asian ancestry, and also it's more common in female patients. So what happens here is that there is occlusion of the aorta, which might lead to the patient presenting with an absent limb pulse or unequal blood pressure. They might be presenting with malaise, headache, intermittent claudication, or signs of aortic regurg. The condition it's not very common, but it's good to know what to look out for, especially because it's quite unusual. And you would manage the condition with steroids, and there's also an association with renal artery stenosis. Okay, so next we have the medium vessel vasculitis. So the first one we're going to look at is polyarthritis nodosa, which is a vasculitis with necrotizing inflammation which leads to aneurysms. It affects middle-aged men more, and it has an established association with hepatitis B. So if you get a question where a patient has these symptoms and also has a Hep B positive serology, then you want to think of PAN. In terms of presentation, it can vary, it can be quite vague, so patients might present with fever, malaise, weight loss, hypertension, hypertension because of the vessel involvement, and they can also have hematuria, renal failure, neuropathy. So remember hematuria, remember renal failure, neuropathy, and Hep B. In terms of tests, okay, so a good way to differentiate, well, actually, that's for the next slide. They are P-ANCA positive, so this is a antibody blood test basically, and in 20% of patients with PAN, they can have a positive P-ANCA. So it's not very specific to PAN. So if we just quickly go to the next slide, as you can see, eosinophilic granulomatosis with polyangiitis was also P-ANCA positive. Okay, so just know that they both can be P-ANCA positive, but nevertheless it can be useful. Hep B serology positive in about a third of the patients as well. Yeah, and in terms of treatment, you treat them with steroids as well as immunosuppressants such as cyclophosphamide. Okay, so the next medium vessel vasculitis we're going to talk about is Kawasaki's disease. This happens mostly in children and it's associated with coronary artery aneurysms. So if a child has Kawasaki's disease, afterwards you want to do an echo to check if there are any aneurysms in the coronary arteries. In terms of presentation, they classically present with high fever that lasts for more than 5 days. They have red cracked lips, they have conjunctival injection, they might have a strawberry tongue, cervical lymphadenopathy, red palms and soles which desquamate. So these are all the signs of Kawasaki's disease, and treatment is high-dose aspirin. This is one of the very few times in which you actually give aspirin in children. Okay, so finally we have the small vessel vasculitis. So firstly, we have IgA vasculitis, also known as Henoch-Schönlein purpura. So in this, patients, usually children, get a palpable purpuric rash, which is non-blanching on their legs, their back, and their buttocks. They might also have accompanying abdominal pain as well as joint pain, but most of the time it's self-resolving, but sometimes patients might go into renal failure and have hematuria. So most of the time, they do self-resolve, and you just need to give supportive treatment even if they have renal failure. There isn't really a cause for it, but some people think that it can occur after an infection. It can be triggered by an infection. Okay, so next we have anti-GBM disease. So this is quite a rare condition, but it presents with lung and kidney involvement. So you might have a pulmonary hemorrhage and a rapidly progressing glomerulonephritis. What's important here is the antibody that comes with it. So in this condition, you have anti-glomerular basement membrane antibodies against type 4 collagen. So just remember your antibodies for this, and remember that the lungs and the kidneys are affected. Okay, and treatment is plasmapheresis as well as steroids. So IgA vasculitis and anti-GBM disease are immune mediated. Okay, so because they obviously are to do with IgA and antibodies. So the small vessel vasculitis that are ANCA mediated are these two. So we have firstly granulomatosis with polyangiitis, which also affects the respiratory tract and kidneys, so similar to anti-GBM. But apart from this, you can also have vasculitis, you can have sinusitis, dyspnea, you might have epistaxis, so nosebleeds, you might have renal failure, which also you have in here, I guess. But you might also get a saddle-shaped nose deformity. So this thing always comes up in questions. And importantly, it's C-ANCA positive, so cytoplasmic ANCA positive, whereas the other ANCA vasculitis is this one, which is P-ANCA positive. So you have to remember which one's which. So the way I remember it is that this is called Churg-Strauss. So I remember that because it's C for Churg-Strauss, it's the actual ANCA that's positive is the opposite, so it's P. Whereas in here, because Churg-Strauss is a P, this has to be a C. So that's how I remember it. And I guess the difference between these two conditions, so granulomatosis with polyangiitis and eosinophilic granulomatosis, is that in here, as it's in the name, you might also, in addition to the vasculitis, the sinusitis, and the dyspnea, you might also have an asthma and eosinophilia above 10%. So this is a good way of differentiating them, and obviously the different anchors. Okay, so that's all the main small vessel vasculitis. So I think that brings us to the end of the lecture. Hope you found this at least a little bit useful. If you have any questions, you can email us on the following addresses. Thank you very much for hanging around till the end. All the best for your assessments, and hope you're staying safe.